Well, hello, everybody. I'm Chris Jarris. I am the deputy editor-in-chief of the Cureus channel, which we call CURiE. And I am joined today by two exceptional authors, Dr. Terita Thomas, with whom I also get to work on the Government Relations and Economics Committee of the ACRO, and with her co-author, Amelia Yalamanchili. And I'll let you introduce yourselves, and then we'll talk a little bit about this very important article that you've written entitled "The Physician Fee Schedule Was Not Built for High-Cost Supplies and Equipment." So, Dr. Thomas, tell us a little bit about yourself.
Sure. Thank you. Thank you, Dr. Jarvis. Thank you, Chris. It's a real pleasure to be with you here today to talk about this article. I know both of us are so passionate about health policy, and this has been a really important piece of work. I'm an associate professor at Northwestern University and have been interested in health policy for many, many years and work across the aisle with our colleagues at ASTRO, ACR, and a number of other organizations, including the ones that co-authored this paper that Dr. Yalamanchili will talk a little bit about. I also am really interested in making sure that we can advocate for what's important for us as physicians and also for our patients, who are just so important to get the best care that they can. So thank you.
And so what I think is really exciting about this is that you are actually in a university setting, and yet you see both of you are actually, and yet both of you see the critically important nature of this flaw in the Medicare physician fee schedule. And so I guess first off, I want to say thank you, because I'm one of the guys who's in the freestanding setting, and so this is really very personally impactful for me. So I want to say thank you, but I also want to hear more about this. And I think Dr. Yalamanchili, go ahead and tell us a little bit about yourself, and then if both of you can just kind of launch into the substance of this.
Sure. Yeah. Thank you so much, Dr. Jarvis. Again, I'm Amelia Yalamanchili. I'm also a member of the ACRO Government Relations and Economics Committee. I'm currently a resident physician at Northwestern as well. I've worked really closely with Dr. Terita Thomas as well as Jason McKittrick, who's also one of our co-authors on this piece. The idea really formed in our discussions about the current radiation oncology payment models, how the physician fee schedule is currently serving physicians in our field in various practice types. I'm in my last year of residency, and so I'm kind of seeing the differences between academic hospital-based settings and more freestanding settings, and seeing some of the differences in both of those spaces. And the ACRO GREC has been very active in this space, has been really instrumental in communicating with other professional bodies, physicians across the nation, as well as industry partners and physicians in other specialties. So, realizing that radiation oncology is not the only specialty suffering from the lack of modernization in the PFS and how we're reimbursed is really important to note, also from a legislative standpoint, and makes some more convincing points when we're trying to really affect change here.
So, Amelia, can you tell us a little bit more about some of the other organizations that ACRO has interacted with, and that you've interacted with in drafting this really critical editorial?
Yeah, so our main co-authors were primarily in the interventional radiology and vascular surgery space. So David Rasmussen, Bob Tahara, as well as Jerry Niedzwiecki from SIR, who's kind of the counterpart of the ACRO GREC. They were all involved with this piece as well. And we can get a little bit more into the details of how some of these inadequacies of the payment system have impacted them as well. But they're also, interventionalists who use high cost equipment, who aren't really being adequately reimbursed. And that really affects them in the office-based setting as well. So they were really instrumental in helping us author this piece too.
So, Chris, just to take a step back and answer the question that you asked in terms of, what is the interest in terms of personally, from me at an academic center, in terms of what is going on with how our field is being reimbursed for what we do. So, I think both of us are of the generation where we were in training, where there wasn't this consolidation in the market, where I'm in a very large city, Chicagoland, and if you look at the density of population in the downtown, but then you look in the cities surrounding us, okay, like like McHenry County, like DuPage County, like further south in Peoria, the population does change considerably. Yet the services that we provide in those areas are critical, especially when someone is having such a devastating thing as a cancer and a more advanced cancer, to have to consider traveling an extended period of time to get their care, when there are other life circumstances like having to maintain your employment so that you can have insurance and have coverage for that treatment that
Right.
you need. So when you look at us in the academic center, a lot of us have seen consolidation within our groups, where we now have network sites, which were once probably independent practitioners or hospital-based practitioners, where there are efficiencies, of course, in terms of potentially quality of care, et cetera, and having that expertise that they can particular practitioners can fall back on. That can be debated. That's not the point of why I'm making that comment. But the main thing to say is that over time, we have seen this consolidation in the marketplace, and that has been a concern in terms of the care that patients provide. And when we look at the PFS, when it was first formed by government in the 90s, it was a very different setting in terms of where people practice than where they do now. Okay. And
I think that's really a good point that you make there. If I'm not mistaken, it's maybe as little as 10 years ago that the ratio of freestanding practice radiation oncology to hospital-based practice radiation oncology has just about inverted from 2/3 one to become 2/3 the other, where or more, that the majority of radiation oncology, which we're talking about in our group, is actually now hospital-based.
And I've had the pleasure of working, in certain environments where we were bringing in particular types of hospitals that had single practitioners or a couple of practitioners, and you can see that they're really struggling to make sure that they can provide the care that they need. And so, in terms of my perspective from this, is that my goal, number one, is to make sure that all our patients, no matter where their care is delivered, is getting the best care that they can. And for them to do that, the practitioners need to be able to have a practice that can support them as patients. Does that make sense?
Absolutely. And
So,
I think, I personally am very grateful to have the ACRO-GREC and people like you, both of you here, and your co-authors who are raising the alarm here. So let's talk a little bit more about the specifics of your message here in this editorial.
Yeah, sure. I can talk to that. So I guess really the key finding in this editorial is that for 195 codes from CMS, the reimbursement is less than the direct costs calculated by CMS itself. So to go a little bit deeper into that, this data, it's all publicly available. You can find it on the CMS website. And when sorting through all of the different codes for which this data is available, there are 195 codes across multiple specialties, including radiation oncology, interventional radiology, vascular surgery, for which reimbursements are less than those direct costs.
So
And those
let's just hit that point there. Let's make sure everybody got that. So there are codes for which CMS's own calculation of what it costs us to do those things are greater than what we're actually being paid. We're losing money by doing those. Is that right? Am I saying that correctly?
That's exactly right. And it's important to note also that those direct costs are just the cost of equipment, supplies, and labor costs, not physician costs. So the costs of running a practice are actually even higher than those direct costs, and we don't have a good calculation for those. So it's likely that even more than 195 codes are probably not being reimbursed adequately, because we don't have the full scope of what it costs to run a practice. And the number of codes that's not being reimbursed just based on direct costs is expected to increase to 300 next year. So it'll be even more services that are not being, paid for what it costs to provide them.
What is driving this then? What is, causing this to enlarge and increase by, sounds like more than 50%?
I think that fundamentally, the government or the CMS was not aware of the fact that there's so many services that we can provide now in the office setting that weren't necessarily potentially being able to be covered in a hospital setting before. And that's one of the issues. For example, our article shows for CPT code 36902, which is a vascular angioplasty, that procedure in the hospital setting is billed 343% more than an outpatient office. So you can just imagine that's a huge number, 343% more. I think what the main issue here is that the billing has not kept pace with the technology.
Well, I think that's really an astounding figure, and I know that there are equally astounding figures in radiation oncology too, in part because I do this. But I think it's important that we make the point here too that there's fundamentally no difference in what is being done for the patient in the outpatient setting versus in the hospital setting. Is that right, or am I misstating that?
That's correct. Yeah.
Yeah, that's right. Yeah, practices like radiation oncology and these other interventional specialties, they really sort of have two different practice settings. Like Dr. Thomas, academic settings that are hospital-based, and then like Dr. Jarvis, more freestanding settings. And those are billed differently, even though the two of you provide exactly the same services for your patients. And I think historically, some of that had to do with some of the overhead costs of running a hospital, but really what it means is that some of these freestanding settings can't sustain providing these services, especially as they see more cuts and they're not being reimbursed the same as they would be in a hospital-based setting. And like Dr. Thomas mentioned before, this kind of leads to the idea of consolidation, the fact that these smaller practices, solo practices, aren't able to survive. And so more hospital-based academic settings are consolidating these practices. And what that leads to is some difficulties with access to care for patients.
Yeah.
As smaller practices in the community are not able to survive, are not able to offer these services to patients, the patients are not able to access care appropriately.
I think that's a really key point that you're making there. Tarita, in as much as fairly said that, there are some potential benefits to, say a university setting, being able to branch out and offer things. But when it comes down to it, small practices being eaten up by larger groups ultimately results in fewer total smaller practices. Do you think that's a fair statement?
I think is a very fair statement, and this is not now this is another point that I wanted to make about this article is that we're not just talking about radiation oncology. We're talking about other interventional practices like vascular surgery, like interventional radiology, like interventional cardiology, where, a lot of these high cost of equipment now in the hospital setting makes it much harder for patients to get that care. And you have to think about all those additional costs, right? If somebody has to go 3 hours away to the big city to get that care, it's not just them missing their work, okay, having to find potentially childcare, finding transportation, finding a place to stay in the bigger city, right? And not only that, not what if there are other things where they have to follow up in a particular period of time? There's a ongoing consequence to society, okay, for us to have this type of consolidation happen. I think it's concerning, and we have to shed light on it. That was our hope with this article, was that we were going to shed some light on it for us to all see that it's not just radiation oncology, it's a lot of us who are practicing in these parameters. So
Well, I think that's really very true, and certainly it's something that I see with my patients. In my situation, I'm about 17 miles further out of the city than most of the providers are, and so I have a certain geographic group that comes to me, and I know that in my situation, if I weren't here, many of those patients would just say, "Forget it, I'm not going to do that," or what have you. Do you feel like that's a risk that patients are just going to go without care? I mean, even beyond radiation oncology, you're talking about some very critical services here, like interventional cardiology and interventional radiology.
well, what's interesting is that, there's another article by one of our colleagues from Johns Hopkins that kind of looks at this concept of radiation deserts, and one of the things that we have to think about is that if people are having difficulties getting care, that maybe their disease gets more advanced. And then when we have to end up treating it, having a more advanced disease, of course, is harder to treat. And, I want to take a step back and say, even within the city of Chicago, so for example, we draw from patients all across Chicagoland and Indiana. And, for some people, it's even challenging to come downtown, even though it's only 10 miles from their home. But, with traffic, I've heard it 1,000 times with, the cost of parking and that it's just as challenging to get into different parts of the city. So I think the main issue here is to think about the fact that certain services like ours in radiation oncology, uh, we have to try to have access in all types of environments where patients live. Okay,
I
so
think you're
that's
very
really
correct there,
the
and
main
and
point.
and I think that that's a huge, hugely important matter. You've got some really exceptional graphics in this editorial, and Dr. Yalaman-Chile, if you would just be so kind, there are a couple of them that I'd like to highlight. Obviously, our viewers can't necessarily see these unless they pull up the article, which they're welcome to do free of charge. But can you just tell us the gist of Figure 1 in the article? It's a pretty dramatic graph that I'll let you detail that for the listeners.
Yeah, sure. So for those of you that might not be able to see this graph, essentially it's looking at the impact of changes in RVUs or relative value units for a variety of specialties. And really what it's showing is that radiation oncology, in addition to some of these interventional specialties, are the ones that have been the most hurt by changes in RVUs. So radiation oncology has seen a 21% cut in RVUs since 2006. Interventional radiology has seen a 37% cut. Vascular surgery has seen a 31% cut since 2006. So these are really, really significant changes in RVUs.
And by comparison, there have been some, I hate to call them winners in this system too, and that are where we're getting a redistribution of those RVUs. Is that a fair statement?
Yeah, that's right. That kind of again speaks to the topic of sort of budget neutrality. So the way that specialties and procedures are paid by CMS are that when one procedure or specialty is paid more, another is paid less. And so there's been a lot of this movement to pay certain specialties like family practice, internal medicine, a little bit more. And because there's one pot of money that everyone is being paid from, some other specialties do see decreases in RVUs. So
And
we
so
see that. Oh,
if I may just interject, it sounds to me like it's quite a bit more than a little bit more. If I'm reading this graph correctly, it looks like it's actually nearly or a little more than a 50% difference when you look at the comparison between radiation oncology going down and some of these primary care services going up. And certainly there's a critical nature of the work that primary care does, and so maybe it's very appropriate that they go up. But at the same time, if we're falling lower and lower, then it becomes less and less fiscally viable to have centers operating in this freestanding setting. Is that your opinion as well?
Yeah, I completely agree. I think it's hard to, say what specialties should be valued at
Sure.
what rates, primary care, internal medicine, they should be valued, but at the same time, those cuts to other specialties like our own mean that, providing the care that we do is just not sustainable. There's been so many technological advancements in our field over the last decade or more, and a lot of these technological advancements are present as well in the office-based setting. So a solo practitioner, a small practice can have the most advanced technology to treat a patient in a highly specialized way. And there are costs with buying those machines, updating those machines,
That's for sure.
service charges for these machines. There's so many continual costs for just providing, basic safe care for our patients. And those can be really hard, especially for a smaller practice too. So continuously seeing those cuts to our reimbursements does really hurt these practices.
And so, Dr. Thomas, I know, and I know that you have these ideas because I agree with you and I've heard about them. But for the sake of our viewers, can you talk to us a little bit about what's the solution?
So, this is an important point. I think that whenever we think about problems, we have to think about, well, what can we do to try to address them? Well, one of the things that is critical is that the payment system, in terms of the outpatient office setting, the technical and professional charges all sit from the same pot of money, okay, funds. And that becomes an issue because as those technical reimbursements, number one, are lower in the outpatient setting, the amount in terms of the RVUs that you saw on that first graph, which is CMS data, I just wanted to make sure I said that, is also then constrained. Okay, so
Let
that
me
one
make sure.
idea. Mhm.
Let me make sure I understand what you're saying, because I think this is really important. So even though the cost of a linear accelerator has gone up and up and up over the past many years, our reimbursement has gone down and down and down, and yet we're fighting against these other forces. Is that right?
That's correct. That's correct. And especially in the outpatient setting, okay, those forces are even a higher downward pressure because the funds for both the technical and professional services actually come from one pot. And that makes it even more challenging for these small practices um, that are independent. So one of the solutions that has been talked about in various ways, one is to remove the high cost of supplies, which is something that the AMA has been very interested in for years and has been advocating for. The other potential solution is to remove the high cost of equipment outside of the PFS. So there are two potential solutions that I think are both are both very good ideas. We just have to have champions for these ideas to help our colleagues in the governmental branch understand what these concerns are. So those are the two potential solutions. One being driven by the AMA with the supplies, and in terms of the equipment, organizations like ours, ACRO, like the OEIS and the other ones that Dr. Yellow mentioned, are hoping to make an impact on that too.
So, okay, now we've been hearing, and either or both of you are certainly welcome to answer this. We've been hearing a lot about Rocker, the proposal that I think Astro came up with originally, and then Acro had some input, and some other societies did too, and it ends up being this very collaborative thing, which is great. Would Rocker fix this? And if not, then what else needs to be done? Or what if Rocker doesn't go through? How
So
is that going to impact all this?
So let me just say that, I think it's a wonderful thing that all of us are putting our thinking caps on, okay, and
Yeah.
trying to think of various solutions for this problem, because this is a huge problem and it impacts so many of us in terms of our practice, but then also our patients. So I think Rocker is a good there's some really good aspects of it, in terms of how they're structuring the payment, how they're structuring the cost of transportation, how they've worked across various organizations to gain support. Okay, I think we have to wait and see. I mean, this is a legislative effort. Okay, a legislative effort is always challenging, but they have good champions for it. We have come as ACRO to support Rocker. We've spoken with, we've done our own due diligence into the legislation, or the planned legislation. We've talked with our various stakeholders, our members, and we've done some very good surveys about what our members think about Rocker. We've also talked with different, vendors to get their impression. So I think we've done a very diligent, well thought through evaluation of Rocker and come out to support it. And we did that, I think, earlier this month, right, Chris?
So Rocker then would remove radiation oncology from the MPFS by and large. Is that
Correct.
right?
Correct. but that would be radiation oncology alone, right? And we are
Okay.
also understanding that this affects other groups as well, right?
Okay, so there's more at stake here with the broader question that you raise of high cost supplies and equipment being a part of the MPFS, and maybe we need to get rid of that even if Rocker goes through.
Correct. Yeah.
Yeah, and I don't think they're exclusive. Rocker is also, it's a good way for us to deal with this issue of high cost supplies. It ideally will also, help equalize some of the inequalities between freestanding and hospital-based settings. So, ideally it will improve some of these facets, but again, like Dr. Thomas said, it would be just for radiation oncology.
I got it. Well, Dr. Thomas and Dr. Yalamanchili, I want to say thank you for writing this enlightening article and editorial. Is there anything that I haven't addressed that maybe we should make sure that people understand about this work?
Well, Chris, thank you so much for having us on this podcast. It's always a pleasure to talk with you either here or elsewhere. I think that what would be interesting is if people looked at this article and looked at the other figures, okay, because they're quite stark when you look at things. Sometimes a picture is worth 1,000 words.
Yeah.
So, if you listen to this podcast and don't have time to read the whole article, just consider looking at the figures. The other thing is that, if you have interest in this sort of work, consider, working with us either at the GRAC, letting us know your concerns or questions about this. We're always happy to hear from anyone who has interest in these issues to build more of a better consensus. So thanks again, Chris, for having me on board today.
Well, again, thank you both so much. And once again, I'm Christopher Jarris. I'm the Deputy Editor-in-Chief of ACRO's journal outlet, which is CURiE. And I've been very pleased to be joined by Dr. Tarita Thomas and Dr. Amelia Yalamanchili, both from Northwestern University. Ladies, thank you so much for your time and for your advocacy for our specialty. Take care.
Thanks. Bye-bye.